Okay. So I'm interrupting well, not interrupting, I'm expanding our bone and soft tissue didactic series to include some stuff from the head and neck today because our friend Peter Sadow is here. Hello. So as you all know, I did my fellowship at Mass General and Peter was my mentor there, and we are still fantastic friends. And as a Pritzker graduate, he likes to come back every year to thyroid CPP. So we did that yesterday, and some of you who were here last year probably remember we did a session together didn't we do a session together for the residents last year? Yeah. So those of you who are here next year expect the same, mostly hopefully better. No, I'm just kidding. So yeah, this is a set of kind of some random head and neck cases that I put together that don't, as you can see, there's a few that maybe have a little bit of a theme, but most of them are just kind of a sporadic sampling of some interesting stuff that kind of, if you don't think about, you may not make the diagnosis kind of thing, and some histologic mimics. So if you got the chance to preview, great. If you didn't, that's also fine. This presentation has like the answers in it with immunos and stuff. So Mike has the link, and then you can send this out like afterwards. All right, let's start with this 81-year-old with a large right nasal mass. Let me hide this panel. Let me hide that. Okay. And awesome, we're ready to go. So, all right, usually for these sinonasal tumors, the initial surgical sort of management is mostly just diagnostic biopsy, right? So they're going into these patients often in the ORs endoscopically to make sure that they have diagnostic tissue. And so if you see a sinonasal mass biopsy on frozen, for example, which is how this came, often they want to know if they have diagnostic tissue, and at most a suggestion of could it not be malignant. They're not often doing the surgical like definitive resection at the time of this biopsy. They mostly just want diagnostic tissue. So that's kind of a good thing with these sinonasal frozens. So this is not the tissue that was sent for frozen, but it's tissue that was sent for permanent following the frozen. So if anybody is anxious to at least describe this case, that would be great.
I can describe. Can you hear me?
I can, go for it.
So looking at this, there's sort of like nests and sometimes cord-like arrangements of cells that have fairly large and kind of pleomorphic nuclei with pale, here it looks like a lavender cytoplasm, but like yeah, paler than the nuclei cytoplasm. For when I was looking around on this, like there's some occasional mitosis, but not super mitotically active. There's some like scattered lymphocytes within it. I didn't see any like keratin pearls or particular like keratinizing features within it. But I'm not as familiar with the morphology to know if you could exclude just based off of that something that's like a carcinoma. There's also, I don't know if it's like a desmoplastic reaction with some of the stroma.
Yeah. Kind of an infiltrative pattern into that stroma.
Yeah.
Okay. So
I'll jump on and say that there's a lot of plasmacytoid polygonal tumor cells.
yeah.
So I'm thinking of like SMARC B1 deficient.
Okay. Awesome. Yeah. So I think, primary, it's lesional, right? Secondary, it seems to be probably infiltrating and highly cellular and occasionally mitotically active. So probably some kind of malignancy. Thirdly, it's arranged in these very linear arrays with desmoplasia. And then as correctly pointed out, these cells with eccentric cytoplasm and an almost rhabdoid or plasmacytoid appearance, which could raise the possibility of a chromatin complex remodeling deficient tumor. So what are you going to tell the surgeon in the OR intraoperatively, and then what kind of immunostains might you want? While you think about that, I'm going to pull up the list of immunos that I have for you.
It's malignant.
Great. Carcinoma, melanoma, lymphoma, sarcoma.
Carcinoma.
Okay. All right. And what are you going to order when you get back to your desk the next day?
I&I. to see if there's loss.
Okay. Damn, you're just jumping right to it. What else?
I'm just gonna say that's an aggressive frozen call. Okay, and I would not, and I am aggressive. Would not make that frozen call at all. You cannot jump to the fact this is carcinoma. Because what Nicole just said, and she gave her differential, it could be melanoma, it could be rhabdomyosarcoma. You know, there are reasons you can argue against plus or minus, but is this the time to do that? No. So if you're doing a frozen, the frozen thing that they want to know is this neoplastic tissue, yes or no? Do you think it's malignant? You know, you say yes, it's malignant, a plasmacytoid malignancy, or you know, however you want to say it. And you can say I favor carcinoma, you can do that, but don't call it carcinoma when it's negative for keratin the next day, okay? So it's not necessary. I guess the point is it's not necessary. You're not looking to prove to the surgeon how smart you are. You're looking to prove to the surgeon, okay, have they done what they need to do at this particular time? And the answer is yes. We have diagnostic tissue, it's likely malignant, and then worry about the list of immunoassays that she's done. And even though you're very strongly favoring something apparently emotionally, I would say, like, that will bear out over the next 2 days, right? Okay.
Right, and I think especially with this morphology, right, of somewhat discohesion, I think melanoma and the rhabdoid appearance melanoma is certainly still on the differential. What I'll tell you how. Does anybody else have any comments before we say what's going on? Okay, so the thing that struck the frozen section pathologists in this case was these occasional kind of intracytoplasmic vacuoles. Here's one, almost like creating a little signet ring type of appearance. So that's thing one. Thing two, there appeared in some areas, oh yeah, here, to be almost like a little single file kind of appearance. So some rhabdoid morphology, some signet ring cells, and some single file appearance raise the possibility, additionally, of something like perhaps a metastatic breast carcinoma with kind of a lobular or pleomorphic lobular phenotype. So I'll at least show you the stains that we have, and then you can come to your own conclusions. So for the carcinoma, melanoma, sarcoma, lymphoma differential, right, here's your keratin 7. So that's relatively well done. Strong positive.
You were right. You were very premature.
The possibility of some questionable, I don't really definitely see keratinization, right? But you have to think about squame in the nose, in any mucosal site, right? This is P40. All right, so non-squamous. This is estrogen receptor, as the possibility of breast was raised intraoperatively. So we did the ER, and there's a weak staining, but non-negative. Like, okay, well, let's try the GATA3, see if that shows anything. GATA3, remember, can also stain lymphocytes, inflammatory cells, so that's probably what that is. But the actual large tumor cells are negative. So metastatic breast with GATA3 negative, probably highly unlikely. And, you know, Regard just hits the nail on the head completely. So this is your stain INI1. So
I was wearing a head and neck like
sure. I mean, you never know. So yeah, INI1. Tell us about INI1.
Oh, I don't know much about it.
Okay. What
I don't actually know what it is.
Okay, you don't know what its function in the cell is.
Yeah.
Does anybody know?
It's part of the SME-SNF complex,
Mhm.
chromatin remodeling complex.
Mhm. So SMARC, oh my God, was it SMARC A1, INI1, SMARC B1, SMARC B1 and SMARC A4. Thank you, SMARC B1, INI1, SMARC A4, BRG1, are chromatin complex remodeling proteins that require essentially a double hit loss to have a downstream effect on the sort of opening and closing, right, of the chromatin on these histones, right, allowing for changes in DNA expression. And so you're looking for nuclear loss, right, in the tumor cells, but specifically, you're also looking for internal control retention in the endothelial cells, the lymphocytes, et cetera. So don't ever interpret immunostains that you are required to interpret loss if there is no background internal normal control. Every single immunostain of which you are experiencing loss, like INI1, BRG1, parafibromatosis, whatever it is, you should always interpret it in the context of positive background control. We've seen consult cases where it's called lost, but everything is lost, even the control, so that's non-interpretable. This is interpretable and in fact is lost. So this is an INI1 deficient sinonasal carcinoma, which now is lumped under these SNP deficient cancers because you can have loss of either INI1 or BRG1. And so the just going back to the rhabdoid morphology or the plasmacytoid morphology, that's a very common appearance in many neoplasms that have the chromatin complex loss. So when you see that morphology, think about ordering the INI and the BRG, and honestly just do both, because in some cases it's more often one, in some cases it's more often the other, but they usually either can happen in the same set of tumors usually. The morphology, specifically these in the sinonasal cavity, can be either these large sheets with peripheral palisading or these kind of more eosinophilic rhabdoid ones that we see here. Sometimes they're very kind of almost small round blue cell like here. So these patients can be put on inhibitors of the sort of histone trimethylation process, whatever. But the bottom line is these are bad, right? So these chromatin complex remodeling neoplasms are often bad, no matter whether they're this entity or other entities. So can somebody give me an example of other entities that have this same genetic background?
Epithelioid sarcoma.
Yeah, epithelioid sarcoma in the soft tissues, whether it be distal or proximal type, is morphologically similar, immunohistochemically similar, has keratins and INI1 loss, and equally very, very aggressive. What else? ATRT of the brain, okay. Ovary, right? Hypercalcemic of ovary has what, BRG1 loss, I believe. Am I thinking of that right? I think that's recently discovered in the last couple of years. Yeah. Okay. Thoracic, there are thoracic tumors now that are primarily intrathoracic, kind of quote unquote sarcomas or carcinomas that have this. So it's emerging, right, in a lot of different tumors.
For the practical purposes,
Yeah.
How well does the loss seen in the IHC correlate with the molecular finding?
Very. So full clean loss, like we saw here, is very correlative with molecular loss. Sometimes with, especially I think more so with the BRG1, you can have like patchy loss or weak, which has some correlation to some BRG or SMARC, whatever loss that might be. I can't remember, there was some article on this that was like, do you know what I'm talking about?
Yeah. Where
Where there's like partial loss or hybrid loss.
Yeah.
Tell me.
Then they're partially responsive to drug.
Okay.
That's the take home. It's pretty correlative. And we're, there are a lot of places that can't do the correlation, right? And so the ability to do the molecular testing is different, but it's pretty much like spot on. And you can have and the reason is important. So these tumors all used to fall under the auspices of SNUC, sinonasal undifferentiated carcinoma. And it's only really been in the last 5 years or so, maybe 7, that we started recognizing these things. And of course, most immunohistochemistry labs didn't. They had INI1 because they've been using it for a long time, but BRG1 was not an immunostain that was present in most of the labs. So now most people actually have access to this. You can see this. But the purpose for doing this is not to like essentially show how smart you are in that sense, or call it unfrozen, but directly unfrozen. But for the purposes of treatment. So if you have hybrid loss of BRG1, those patients tend to do better response to treatment. But as Nicole had mentioned, these patients overall do very poorly, and they do very poorly in the context of the fact that it used to be SNUC, which used to be like, this is a horrible diagnosis, you're going to die with sinonasal undifferentiated carcinoma, and they still do, but maybe a little bit slower because of the medications that can be somewhat effective, especially if you're. The primary thing is surgery. So if you're able to do sort of a near total or almost total resection of the tumor, then giving patients adjuvant therapy prolongs their life for years. Versus, versus months or something like that without being able to resect or have drugs.
Yeah, so they didn't do like an en bloc resection here. They went back in a second procedure and took out a debulked as much as they could and then gave her therapy, but yeah, she ended up dying. Okay, questions, comments? So I just wanted to remind you of the burgeoning sinonasal carcinoma sort of area. So, SNUC, as Peter said, right, was kind of this wastebasket term where if you didn't know the molecular or the underlying, whatever, it was just it was a SNUC. Now that we have the molecular on so many of these other things, like NUT, like HPV related multiphenotypic, like adamantinoma, like Ewing's, like this new DECAF, we can look at morphology of these together some other time as well. I don't necessarily need to belabor the point now, but once you remove all of these, right, now SNUCs have actually recurring mutations of IDH2. So they are actually a specific entity now, kind of in and of themselves, right? They're not just actually wastebasket, they're an additionally molecular defined tumor. Once you've siphoned all of these out, you're kind of left with that, if that makes sense.
Do they always have the IDH2 mutation or?
I believe most of them do.
70% of what's left of SNUC. So like I say, most of these actually fell in that category before, and now they've been molecularly removed. And so now IDH2 mutation is about 70% of what's remaining of SNUC. So there's they're IDH2 mutant sinonasal carcinomas, but parenthesis SNUC, right? Because then there's also some of them that have mild neuroendocrine differentiation, et cetera. One of the tricky ones here that Nicole just mentioned is this DECAF2, which has been fairly recently described. The issue with that one is it also can be a very aggressive tumor, and nobody has the assay for it. So you can recognize it morphologically. Oh, this looks like DECAF2. And everyone will start discussing it, and then you're showing a case around, and it's sort of like, oh, do you have that probe? We can send it. No. There's like a small lab in Dallas, Texas.
RNA fusion,
Right.
RNA sequencing.
Yeah, it's really hard to get it.
Yeah, we, I don't know, if those of you who were at IRAP a couple times ago, there was one of these presented, from North Shore. I have the slides on it if y'all wanna see it at some point.
Yeah, it's cool. But the reason I say is we had one, a few weeks ago, one of our faculty got one, and it was for a sinonasal inverted papilloma. And she's like, oh my God, I think that's DECAF2. And it was legitimately like a 1 millimeter focus that I would have even looked at, because I'm apparently irresponsible. But I wouldn't have even noticed it, and I would have passed it over, just called it sinonasal inverted papilloma. And they started getting all over it. And then another one of my colleagues, oh, I think it is too. And then took a picture of it and sent it to someone in Texas who's like, oh, I'm pretty sure it is also. Like literally it's a 1 millimeter focus in this 20-something-year-old person who the cure for it is like this massive resection of a person who just basically went to get like sinus surgery. And so they sent it to Texas to get this fusion where it's now been sitting for 3 weeks and hasn't come back yet. But they surgeons interpreted the results because it says in the computer sent out, like says DECAF2 fusion. It's like they interpreted it as being positive when the result isn't come back. It's because it just says
Like
DECAF2
pending
fusion.
fusion,
Yeah.
yeah.
And it's like it's still not back, but it's scary. And I would argue that in a case like this, that I announced I would have missed it, that I actually would have been appropriate to miss it. Because if you're looking for something that's going to cause a massive surgery, like meaning if this is a bad thing and it's going to come back, it's going to come back and present itself as a bad thing, after this original surgery. But looking for like in this one slight like sub-millimeter focus and a sinonasal papilloma is kind of insane.
Yeah, so remind me when we're back in the head and neck section, we can do more fleshing out of the morphology of the rest of these.
They're fun.
They are fun. But for today, because we have a little bit of a theme, we'll move on to the next case. Another sinonasal mass undergoing biopsy. So, oh, this case is from you. Who wants to describe it?
It's kind of pale, lots of pink in the background.
Mm-hmm.
I'm a little biased because I'm from GU world.
Yeah.
It reminds me
Tell
of
us.
something that could be from GU or mimic something that
Yeah,
was from
specifically what?
clear cell homophobe
Mm-hmm.
has that like pretty bland looking nuclei
Mhm.
around. Has this cleared out cytoplasm that is often optically clear. It has very pronounced cellular membrane.
Mhm,
I don't see any mitotic figures in this field.
mhm. All right, so something very optically clear in kind of these nests and almost tubular-like structures with some kind of serous stuff in the middle, with a vascular background that, yeah, mimics clear cell RCC. So how do you wanna prove it somehow?
Yeah, I guess if the patient has a history of
Okay,
clear cell, then I would go out my way to prove it.
okay,
Um,
and if they don't,
I would still prove it, but
Yeah.
it's a kind of unusual location for it to appear.
right,
But I guess we could throw stuff like CNI.
Mhm. what else?
I don't know how far I would go. It looks pretty low grade, so CNI should be pretty bright.
Okay.
If it was from, world.
Okay,
Um, I don't know. I don't know. I'll probably wait for CNI.
okay, anybody else?
Low power, it reminded me of a sinonasal adenocarcinoma just because of the
Mhm.
back lens.
Yeah.
So I'm wondering if there's like a subtype that's renal cell-like,
Mhm.
but I don't know if there is.
Have you,
I haven't read about it.
have you been reading the WHO? So, yes, so if you were to do only your CA9, it would be
Oh, I see.
positive and you'd fall into a trap.
Yeah.
So this is a renal cell-like primary sinonasal adenocarcinoma. The important thing is it's negative for PAX8, right? So you can distinguish these by immunoprofile. In fact, as you pointed out, it does appear there's not a lot of mitotic activity, there's not necrosis. Most of these are low grade. Some high grade cases have been reported, but essentially this is a low grade primary sinonasal adenocarcinoma, which like most cases, right, will undergo surgical excision with some additional need for adjuvant therapy in some cases, right? But immunohistochemically, it's important to prove that it is what it is rather than a met, because you of course you can get mets. You can get mets to the sinus, you can get mets to the jaw, you can get mets to the salivary glands, right? So when you have these morphologic mimics, you pretty much are required to prove it.
How brightly is it positive for CK7?
I don't know, do you know?
No, I don't actually remember, but it's overtly and definitively negative for PAX8, which is the most important part.
Okay, yeah.
And the other thing you mentioned, because you started mentioning things about mitoses, but of course, if you were looking in the kidney
Yeah.
and saw that, would you be looking for mitoses?
No,
No.
it's not.
No.
Yeah.
So they're not mitotically active in the kidney, they're not mitotically active in the metastases, and they certainly, if it isn't, and we do, RCC actually is one of those that we do see in the head and neck, not infrequently. So it's definitely something to keep in mind, but having no history it would be kind of unusual to make the primary diagnosis in the sinonasal cavity, but we do see it.
I don't know the answer to this, because I don't sign kidney, right, but is primary kidney renal cell CK7?
Typically
CK7
not.
negative, okay.
Yeah.
So that could be, okay.
Yeah, so papillary renal cell carcinoma would be CK7 positive.
Got it, okay, cool, so those two things are helpful. What else? Comments,
And
questions?
chromophobe, so then he brought up chromophobe, but the thing is that they're also CK7 positive, but the nuclei, even though there's some prominence of the cell membranes here, the nuclei are not chromophobic.
Right. And all of those as renally derived would be positive for that, yeah?
Yes, and chromophobe, if it was chromophobe, as bizarre as it would be to see a met and to the sinonasal cavity without having a primary, see a met of a chromophobe, which basically doesn't metastasize and be the herald of it would basically obscene.
Perfect. This wasn't on the original unknowns, but I just wanted to bring it up as a reminder, right, of what other neoplasm we can see that's primary in the sinonasal cavity that is another morphologic or metastatic mimic, right? So what am I trying to show you guys?
This is a great one. Where do you think you are if you weren't told where you are?
Prostate.
This intestinal.
Yeah, I think
colon.
I think colon.
Colon.
Yeah.
Yeah, so really complex branching gland with this central kind of grungy necrosis with these very elongated open nuclei with prominent nucleoli. Yeah, this mimics colon cancer, right? So this is sinonasal, right? Intestinal type adenocarcinoma. But how in this case do you exclude a colonic metastasis?
CDX2.
CK7, CK20, CDX2. I'm not
Okay.
sure if they're gonna be positive, no primary. I feel like they won't. Like CK7 would be, CK20 may be negative,
Okay,
the CDX2 may be negative, but I don't know.
okay, so if you threw these immunostains on there, does anybody predict what the pattern's gonna show?
Same.
Same, so CK20 is gonna be positive, CK7 is gonna be negative, CDX2 is gonna be positive. So how do you exclude a colonic metastasis? What?
MMR.
Okay, even before that, I mean, not before that, but even,
Say the pathologist can't exclude that it's a colonic primary.
Colonoscopy.
colonoscopy.
There you go. See,
You're allowed to say that, and what other, so pertinent negative, right? The patient doesn't actually have a primary colon cancer. And pertinent positive, what will this patient have?
Actually,
No. Not that you can see with your eyes. Something that has to come from the patient themselves.
Exposure history.
Yes, exposure history. What is the carcinogen in these?
It's like, oh my god, it's not leather workers.
Yes, it's occupational wood dust, leather dust, all kinds of inhaled carcinogens, right? So this is a board, like every single year they ask this, so you gotta know it, This is sinonasal intestinal type adenocarcinoma, it stains like colon cancer. It's related to kind of occupational inhaled carcinogens.
And it's also it's likely in the spouse of the person who has that. So if it's not a word worker or someone who works with shellacs,
It's their spouse.
Yeah, you ask the spouse about the spouse's history,
It's
because
their
actually it's
pa-
interesting. Yeah.
Partner.
Or yes, or special friend, I don't know.
Special. So, let me just, when you get this, you guys know the drill, you can click on the little do I have a little information button up? No, I don't. In any event, right, so we can tell what this is. So this is CK20. This is CDF2. There. I don't know if anyone has looked at STAT-V2 in these, because STAT-V2 is colon, right? You know?
No, it's also upstairs.
It's also everything.
Right,
It's also
like what is
everything.
it positive, but no,
Fine, fair enough.
we could do this quickie.
Yes, we'll do a quickie study.
Yeah.
All right, so next case, buccal space. And there's avidity in this patient, in the PET scan, both in the prostate and the buccal mucosa. So who wants to describe?
This is the one that I was looking when I was previewing. It could look like prostate.
this looks like the other one.
Pardon?
It's kind of like the other one.
Yes.
It looks so similar.
It does, it has pseudostratified elongated nuclei, it doesn't have the dirty necrosis.
It doesn't
Yeah,
necrosis, and it does have
Prominent.
probably so.
very prominent nucleoli, and so Mike is like, wow, this kind of looks like prostate cancer. And it kind of does, but it's in the buccal mucosal space.
There's no desmoplasia either.
There's no desmoplasia, there's a little bit of biopsy site, so this is a resection following initial biopsy, so there's a little bit of a biopsy site, oops,
It looks a little more like BPH than it does colon
it looks a little bit more like,
cancer.
but there's
There are prominent nucleoli.
nucleoli, there's mitoses.
Yeah.
There doesn't appear to be a bounding sort of basilar myoepithelial cell layer, right? If you're thinking about something arising within a ductal system, whether it be, salivary or prostate, right? But obviously if it's a metastatic prostate cancer, it wouldn't have its basal cells. It's adjacent to some atrophic salivary tissue. So this is one that I learned about in the past year and has recently been described. So unless you all know what it is, who knows what it is?
Salivary carcinoma.
Well, no, salivary duct carcinoma actually doesn't look like this, right? Salivary duct carcinoma looks like kind of like apocrine DCIS, right? With lots of necrosis, with very eosinophilic cytoplasm. Yes, there's prominent nucleoli, but this is a little more architecturally different, with these very elongated papillary-like structures, without necrosis, without apocrine change, all right? So not salivary duct, but
Introductal.
some other kind of some other kind of cancer that resembles a duct-like process. So, this is what happened in this case. So the patient, because of the PET scan showing the prostate avidity, they actually went and looked at his prostate and did biopsies. There was nothing. PSA and PSAP on this case were negative. The issue here is that NKX 3.1, which was performed on the outside, was positive. So what is NKX 3.1 marking? Prostate, okay? So how do we interpret that? Well, we now understand that there is a specific type of salivary carcinoma, right, that has NKX 3.1 expression, prostate-like morphology, right, but specifically an AKT1 driver mutation that it defines this entity, right? So this is this kind of sometimes regarded as intraductal if there is a basal or myoepithelial cell layer at the periphery, but in this case we weren't able to define a myoepithelial cell layer. So these would be regarded as invasive cancers, however potentially low grade. But I believe it now technically they're lumped under a subset of salivary carcinomas called mucinous adenocarcinomas, some of which have different relative amounts of intra and or extracellular kind of mucin. So this is a case that has maybe some intracellular vacuolization or some secretory myxoid material, but doesn't have a lot of stromal kind of colloidal mucin. But I believe it's lumped under the quote unquote mucinous adenocarcinoma kind of framework. But that's the other mimic, right, is the morphology and the immunoprofile that can mimic prostate. I know you probably.
No, I just like, I like it,
Familiarity.
that says up to 100% of cases, meaning either 100% or not.
Mhm.
It's up to, but it could be 46%.
It could be 46. Well, it's like, you know, one study says it's 95 and the other says it's 100. So yeah.
And the other issue here, of course, is that, you know, that PSMA, which we've been using much more frequently, is prostate-specific membrane antigen. And that would really freak everybody out.
So cool case. I learned a lot from this.
Because just for the people that, you know, like just the NKX 3.1 and PSMA are prostate-specific markers that are often used in the context of trying to rule out metastasis, because particularly when prostate cancers go bad, they lose PSA, so they are often PSA negative. So the fact that it's PSA negative, and that's the reason why they kept probably rebiopsying the prostate, the fact that it's PSA negative and PSAP negative, prostate-specific alkaline phosphatase negative, is that, you know, those markers tend to be lost either. This is what doesn't look like an aggressive one, like super high grade prostate cancers and metastases often lose those markers. So seeing the very specific prostate markers being positive and these other ones that tend to be lost in metastasis would be freaking out, and of course they're going to keep stabbing. So in this particular case, the helpful thing would actually be getting the molecular.
Cool. All right. Questions? Carotid, 38-year-old with carotid mass undergoes core biopsy. So, you know, diagnoses on full, beautiful resection specimen, right, allow you to fully view the entirety of the tumor and come to some thought process, but core biopsies, right, can be really challenging because you have a limited amount of tissue, right, and you have to make the diagnosis of benign, malignant, you know, subtype, et cetera, based on often scanty things. So this was a challenging one, but we will end up having an answer. So 30-something-year-old with a lesion of the carotid. Who can describe it? Are the cells spindled or epithelioid? Spindled. Do they have any particular pattern that we can tell?
Almost kind of like Ruke bodies.
Okay.
Almost.
Okay, so you see some palisading,
Yeah.
you maybe see some pink matrix in the background, okay? We talked about the morphology of nerve sheath nuclei last time. These are not quite perfectly buckled or pointy, right? They're a little more ovoid, but we know that that's a possibility, right? So we've got a differential of something Schwannian in the salivary gland, what other cell type or neoplasm can be primarily or abundantly spindle? Pardon?
Myoepithelial.
Yes, so myoepithelial cells, right, can have, they're like a syphilis or like a melanoma morphology, right? They can present as anything. They can be plasmacytoid, epithelioid, clear cell, spindle cell, chondroid, like they can present as
They are
anything.
not like syphilis.
They, great masquerader, right? Wasn't that? So yeah, so I would think about that differential here as well. Since we're short on time, I'm happy to
What is the
just,
pattern? It's syphiloid.
it's syphiloid. Come on. Okay, so who favors what? Schwannian? Myoepithelial? Don't know. Awesome. So we didn't know either, so we did all the stains, okay? So here's another core biopsy that you guys can look at your leisure, but pretty much doesn't show anything extremely different. In some areas, more or less, myxoid stroma, more or less palisading, et cetera. So the first stain is, I believe this is, yes, this is EMA. So why did we do EMA?
Perineural.
For perineural cells, what else stains with EMA? Myoepithelial cells often stain with EMA, right? So how do you interpret this? Unconfidently. Yep, exactly. So there's some weakness. Is that because the tissue is poorly immunoreactive? Is that because there's actually some EMA? Or is that just because there's some non-specific reactivity? Exactly, I don't know either. So the next stain is calponin. Why did we do calponin?
Also stains myopathy.
For myoepithelial cells, exactly. So there's also some blush. Nothing that's like, wow, strong, hit you over the head. However, this is pretty strong. This is S100. So now where are you?
Are
So-
you?
No.
Something neurocrustal.
Can myoepithelial cells have S100? Yes, yes, they can, okay. Right, you know that it's probably neural crest derived or it's something that has S100 expression. This one we did was, oh, the scan is really bad. GFAP, why did we do GFAP? What in this differential can have GFAP expression? Myoepithelial cell tumors can have GFAP expression, all right? This is more common in myoepithelial tumors of soft tissue than myoepithelial tumors of parotid gland, but we can throw it, we have the stain, so we're gonna throw it on. Peter sometimes likes to use collagen 4 and laminin in nerve sheath tumors because they are supposed to highlight individual cells rather than groups of cells. So we try to see if the individual cells are outlined by collagen and laminin. And it looks like there's quite a lot, not really surrounding groups of cells, but surrounding individual cells. But honestly, I don't do this stain in myoepithelial neoplasm, so I have no idea what it would look like. So after all that is said and done, do we have a diagnosis?
We do
Who now restructures after the eye cheese? What?
We do a soft tag.
Ah, yes. So when you have,
Did you do any of the practical?
yeah,
Immunostain?
yeah. So I may have misspoke. One of those I think may have actually been a SOX 10 instead of the GFAP. I think I missed my cues. But yeah, so usually when S100 is positive, SOX 10 will also be correlatively similarly positive. So yes, in this case, there was SOX 10 expression. Does that still help you?
That's positive in both also.
Yeah.
But P63 might help me, or keratin 5-6.
Right, so something more specific to a myoepithelium, right? Like a high molecular weight keratin or a P63. And in this case, they were negative. So I was not ready to commit to Schwannian versus myoepithelial because I'm weak, right? I'm weak and I was not secure. So Dr. Blair goes in, she's like, all right, this is a young person. She wants to spare as much as she can of her you know, parotid and facial nerve, and if you tell me that this is, you know, something. Certainly if you tell me this is something benign, I'm not gonna do a wide resection, I'm just gonna kind of debulk it. So this is what she sends for frozen. And she wants to know more clearly what we think it is.
I mean, the core biopsy was pretty good.
The core biopsy was pretty good, I just was not ready to commit,
I understand, but you
But-
know,
you all probably were. So what is it?
but
Yeah.
they usually, but they also usually present symptomatically, right? That's
Right.
usually, the biopsy is usually painful.
Yeah.
For schwannoma versus being sort of painless for,
Yeah.
but maybe the patient didn't jump through the ceiling when they shoved the
No.
needle in.
She didn't.
Was she a
and-
veteran?
No.
Was she a 90-year-old veteran?
She was a 38-year-old woman, and no, there was no pain, and you know, in intraparotid, like to see a primary nerve sheath tumor within the parotid, I think I was just reticent to call it on biopsy because of the overlapping immunoprofile. So I chickened out, but I think on the frozen we got it. So she even said herself that there was some attachment to the facial nerve. She's like, okay, fine. So you guys already appreciated the varicate bodies and the palisading and the fibrillary matrix on the core biopsy. It persisted. So yes, this was an intraparotid schwannoma, essentially of the facial nerve. But I think the lesson is that for me, right, is that myeloepithelial cell immunoprofile can be very overlapping with Schwannian immunoprofile because they're these are just repeats on some of those stains.
So what are good stains to differentiate them?
Yeah, so I mean, a strong keratin, you basically need for a myeloepithelial cell, you need some kind of keratin or EMA. The EMA in this case was so weak, right? It was unfortunately extremely weak. But since this was an outside tissue, it was hard to sort of trust the quality of the processing for me, right? But on our in-house EMA, it actually was a lot weaker. So where did I go with it? So I'll show you our in-house EMA. So yes, if you had a wonderfully strong keratin, you could pretty much say that you are no longer dealing with a benign schwannoma, right? So this is our EMA, which I think is a little bit cleaner than that other one. So
So if that's something like in combination, you have P63, P40, cytokeratin 5/6 would be positive myoepithelial cells. But then sometimes you don't know. So like, so just as Nicole said, she didn't want to make the call that way, but the other thing would be preoperative imaging. This is growing off of the facial nerve, right? So you don't necessarily have to do it entirely pathologically. You actually have clinical information that feeds you, and then say in combination, the findings are most suggestive of or highly consistent with or something like that. So that's kind of, and truly the excision in this case didn't look too dissimilar from the biopsy, but the biopsy being parotid, you'd be like, okay, it looks Schwannian, but it's probably myoepithelial based on the location. But then if you have additional information, then that can help you. But if you had this and you did P63 was negative, P40 was negative, cytokeratin 5/6 was negative, and the Schwannian marks in there, you're like, you may favor schwannoma in that particular circumstance, but a myoepithelial neoplasm cannot be excluded. I mean, that's how you'd have to go.
Right. And not all myoepithelial tumors are P40, P63
Right.
positive, right? So that's
That's the
it's
reason why.
always a
yeah,
panel.
it's a
Yeah,
panel.
it's always a panel. But keratin would have been the best one, probably.
So when you say like a myoepithelial neoplasm,
Yeah.
which ones would you favor most in the, like, with that morphology?
So what are your options?
I mean, I could look at the WHO classifications right in front of me.
What are your options for myoepithelial rich neoplasms, just off the top of your head?
Myoepithelial carcinoma.
Myoepithelial carcinoma,
It's malignant.
Epithelioma.
myoepithelioma, which arguably some of us believe is just a variant of a myoepithelial rich pleomorphic adenoma,
Right.
right? Because most of these tumors, most of these benign salivary tumors that are myoepithelial rich end up having some focal duct-like formation or chondroid stroma or both, right? That you can say, okay, this, because by definition, right, PA is biphasic. You need epithelial and myoepithelial. I pretty much have never seen a pure myoepithelial tumor of the salivary glands that is not malignant. Do you agree?
Yeah.
Okay, so basically you're dealing with a myoepithelial rich PA or a myoepithelial
Oh, I
carcinoma.
see. Okay.
even though you will read about myopithelioma in the WHO, I think not many of us actually practicing believe that it exists.
Yes, Bill.
Except Bill. Okay, so there's another parotid core biopsy. I think this one is interesting, kind of for different reasons. So this was now a 72-year-old male. Okay, but I put these together because they're similarly of spindled morphology, right? What's different between this one and the prior one? It's malignant. Okay, great. There's tons of mitoses. There's this grungy, nasty necrosis. Okay, so now we're dealing with a malignant spindle cell neoplasm. Oh, there's your nice necrosis. There's some maybe myxoid degenerative change in the background. There's another mite. Okay, so now how are you going to shift your differential, or are you?
It's not a schwannoma.
Could it be an MPNST? Could be. Well, the thing with the prior case was on imaging. No one was willing to commit that it was on the facial nerve, but intraoperatively, Blair was like, "Oh yeah, it is." Okay, fine. So, all right, now we're dealing with a malignant spindle cell neoplasm with myxoid background. Who wants what? Here's the resection specimen. Because I don't have scan stains on the biopsy, I only have scan stains on the resection. So just to prove to you that it all looked the same, right? It's ugly, it's spindled epithelioid, myxoid cystic change. Certainly infiltrative, right? Spindly. Do you still want to think about something myoepithelial since we're in the salivary gland? Sure. What else do you want to think about? Melanoma, always. Okay, so I'll just show you what we have, right? So this was a keratin, this was an outside Oscar. Not bad, eh? All right. This was a P63. Okay, so with keratin and P63 now where are we down to? Squame or still myoepithelial, right? So tell me if your differential is squame versus myoepithelial, tell me about that. How are you, does it matter?
I think P40. Oh.
So P40 is positive in myoepithelial too. Sure, so exactly. So the other myoepithelial specific markers that are positive in myoepithelium only, but not in squame, right? So these are the overlap with the Cipriani ones. These are the S100s, these are the SOX10s. These are the myoid markers, right? The contractile filaments like SMA, like Desmond, like calponin, right? So when you're talking about squamous, right, your high molecular weight keratin and P40 and P63. When you're myoepithelial, you're that plus S100 and SOX10 and calponin and Desmond and SMA, right? And when you're schwannoma, you're just S100 and SOX10, right? So it's a Venn diagram, right? With myoepithelium in the middle and Schwannian and squame on either side. Am I describing it correctly? So in this case, we at least are not where we at least are in the one side of the camp. So we have I think this was P40. Yeah, this was P40 because this was P53. This was P40, so definitely something in the nucleus. This was smooth muscle actin, maybe something weak in the tumor cells or dendritic cells, but mostly the background muscle. Okay, and then calponin. Calponin, I don't know, sometimes has some weird dirtiness, but there's some dirty stuff happening with the calponin. S100. So S100 I would be careful with, right? Because there's always dendritic cells in tissue. So make sure that the things that you're looking at are actually tumor cells and not dendritic cells, right? So dendritic cells may have small nuclei, may have wispy, pointy cytoplasm. So arguably there's a lot of these with branchy, wispy cytoplasm, but one could arguably, construe focal tumor cells as S100 positive. I can't really argue that. So we're not really in a you know, 100%, but nothing smacks you over the head strongly positive from the myoepithelial stains. So if you wanted to 100% confirm your impression of squamous versus myoepithelial, what could you do? Pardon?
With all the mixoid matrix,
Mhm.
it seems to favor myoep.
Okay.
As you could do molecular. 'cause
Okay.
carcinoma has that fusion.
Cool. So yeah, so you could think, okay, there's a lot of mixoid myoepithelial cells tend to produce mixoid matrix, so morphologically, I might favor myoep, but we can prove it with molecular. And so you are looking for what rearrangement in myoep?
EWSR.
Right, so many myoepithelial carcinomas and EWSR1 rearrangements with variable partners. And what would you be looking for in squame? Nothing. Well, are squamous cell carcinomas of the parotid primary?
Usually not.
Where do they come from?
The skin.
The skin. So what could you find on molecular?
UV
UV signature. So the way that our lab works, and you know, you guys who've run through it recently can correct me if I'm wrong, but if the tumor mutational burden is above a certain threshold of high, 15, I don't know what it is, 20, whatever, they will go and look at the cosmic mutational signatures to try to assign a pattern to it, a cosmic pattern. And so the ultraviolet signature has predictable transitions, right, in the C's to T's or the C to T. And so if you have a high enough mutational burden, you can look at that profile and say, oh yes, there's a ton of C to T transitions across the whole genome, right, non-specific pan genome, and map it to having a relationship to ultraviolet signature. And this had that, right? So this had a UV signature. So this was a metastatic spindle cutaneous squamous cell carcinoma. Most of the squamous cell carcinomas that metastasize to the parotid are keratinizing. And you can say, yes, this is a keratinizing SCC. Yes, this is usually it's an old man of pale skin who has had some exposure, farming, golfing, suntan, whatever, right? There's usually some sun exposure history. There's sometimes a known skin cancer history, but not always. You know, maybe they got something burned off or picked off or whatever, and they don't remember, but it pops up in their parotid years later. These tend to be, I don't know about the spindled ones because that's pretty ugly, but the conventional keratinizing ones tend to actually behave better, less aggressively than primary high-grade salivary carcinomas that have either squamous or non-squamous differentiation, right? Like high-grade mucoep or high-grade whatever. So if you actually have a squamous met to the parotid, these behave more like just kind of locally traveling skin cancers, right? That you can excise and follow, and these patients generally do not so bad as a primary high-grade salivary cancer. Which is important, I think for me, important to make that distinction between a met and a non-met because you're prognosticating for this patient.
And these patients also respond to pembrolizumab.
Mm.
So the
Right.
And the other thing that Nicole pointed out when she showed the beginning of the biopsy was like how ugly it was. So myoepithelial carcinomas don't typically present like that. They don't typically look like that. They tend to be a little bit better, but they can have high grade transformation, but they're not typically going to present like this in an old person. It's going to be something that's been around for a really long time. It may have undergone, so the patients had a parotid mass for like 15 years and then sort of ignored it or something like that. But these in old people are typically scalp mets. And they respond very, very well both to surgery and to subsequent. And in these cases, at least in our hospital, they don't even ask us to get PD-L1. They just treat them with pembro.
Did they end up finding the primary for this case? No.
You know, the thing is with these mets, there's usually not an active primary. It's usually something distant, something regressed, something that the patient kind of forgot about. Because if finding the primary would be easy, right? That diagnostically correlative and easy, but it's in these cases, mostly there's no primary. This has even happened with melanomas. No shit. So we had a ugly, like, neural crest positive tumor. Again, that was like S100 SOX10. Is this a myoepithelial tumor, right? Or is this a metastatic melanoma? And so you can prove that genetically also, right? Similarly with UV signature or with specific melanoma mutations like NF1, you know, BRAF, NRAS, whatever. So we also had a metastatic melanoma to the parotid that we were pretty much able to also confirm based on that mutation, because these often also lose other melanocytic markers, right? They lose HNV, they lose melanA, they just maybe retain the S100.
And we've had situations, a lot of them where they retain nothing. So
Exactly.
all the mutations,
Exactly.
if they're not positive for keratin, so it starts helping to rule out squamous cell mets, but then
Right.
they're positive for nothing. When they're positive for nothing, it's this high grade ugly thing, it's like, okay, this is metastatic melanoma, and then we go ahead and get molecular, and the molecular actually helps with finding the mutations that we'll mention. We typically also, if it stains for nothing, we then throw on like a BRAF V600E stain just to see if that's possible, because also that gives an opportunity for treatment.
Yeah, for sure. All right. We're at 9 o'clock, so I can probably stop. We've got some additional lesions that we can do. Now, if you wanna continue, we'll do these another time. 'Cause I don't wanna take up all your morning, so. Thanks.
Thank you, everyone, for coming and flattering an old person. This is the 20 year anniversary of my graduation from this medical school. That's not live.
The future looks bright for all of us. And I'll put this up on the drives.